I'll be talking on periprosthetic fracture, which is one of the most dreaded complications in total hip replacements. Can I have a pointer? This one? Yeah. So let's see the incidence. So intraoperative fractures are shown to be about 3.5% in the primary uncemented hip replacement and 0.4% in cemented arthroplasties. And post-operative overall rate is around 0.1%. And post-operative, most commonly it is seen at the stem tip. Now, intraoperative acetabular fractures. What are the risk factors? Under-reaming, most common risk factor. We tend to under-ream and then we try to fit in a bigger cup, which is more than 2 mm. Then we can break the medial wall, we can break the columns. These are the main. Over-reaming can also cause fractures if you are actually compromising on the columns itself. Elliptical modular cups are known to cause these fractures. Osteoporosis, one of the major reasons. Cementless acetabular components needs banging in so they can actually fracture the acetabulum. Dysplasia of the acetabulum or previous radiation history. So if you have an intraoperative acetabular fractures, most of the time, if it is a very small fracture, you will not realize it on table. Okay, you will realize in a post-op X-ray. Sometimes you have a small kind of a little bit protrusion, then you can realize on table. But this is something which is a very big complication, which you have realized on table that you have broken the columns. Then you need to fix it on table itself. If it is a very small fracture which you realize on afterwards, then maybe you can consider protected weight bearing and observation alone. You can have addition of acetabular screws to just stabilize your cup just for a better sleep. You can consider upgrading to a jumbo cup for a better fit. And of course, bigger fractures need ORIF of the acetabulum with revision of acetabular component. If the posterior column is compromised, then ORIF plus revision is the most stable construct. Coming to intraoperative femur fractures, the risk factors is the Indian female with a very small femur, the champagne glass type of femurs, cementless implants, osteoporosis, impaction bone grafting, trial using undersized stem, and revision. Revision itself has shown to have a higher risk of intraoperative fractures in femur, up to 18-20%. This is the Vancouver classification of intraoperative periprosthetic fractures. These are basically divided into 3 types, A, B, and C. A is the proximal ones, A is the proximal part, B is the middle part, and C is the distal fractures. And then again they are subdivided into 1, 2, and 3. So A1, type 1 is usually the cortical perforation only. So whenever you see A1, B1, C1, these are only perforations. When you see second type is A2, A2 is basically simple fracture which is not displaced. So A2, B2, C2 are undisplaced fracture, and then type 3 is a displaced fracture. So whenever we are looking at A type fractures, okay, suppose there is a small LT fracture in the calcar, you can get away with a simple circlage. That should not be a problem. Even some GT fracture on table you can manage with some plates and wires. Okay. Whenever there is a B or C type fractures, you need to, for a B type fracture, usually we go for a longer stem, distal fit implants, all those different kinds of implants are available. If you have a type C fractures, then in that case you can do plating, distal femoral plating. This is a Vancouver classification for post-operative periprosthetic fractures. Now this is divided into again A, B, C. Type A is GT type, then LT type. Type B is type 1, type 2, type 3, 3 types of B are divided. B1 is basically fracture at the tip without stem loosening. B2 is with the stem loosening, and B3 is a very comminuted type of fracture with everything is loose. And type C is much away from the stem. So this is a type with a GT type of fracture. For a LT type of fracture, usually we don't need to do much. Most of them are very stable. We can wait and watch, and usually they heal well. GT type of fracture, it's a very slight displacement. Sometimes you can leave them alone, non-weight bearing. they heal well. X-ray may show that it is displaced, but still they have good abductor mechanism. And many a times we do need to fix it. We can fix it with wires, tension band wiring or plates. In B1 type fracture, now B1 and B2, this is the most confusing type of fractures because there you don't know whether the implant is loose or not. Okay, so only difference is like X-ray will show the same to same picture, but when you go in, you find the implant is loose, or sometimes the implant is not loose. So you have to be prepared with B2 also. This is a X-ray of a fracture. Supposedly B2, it was initially thought that it was a B2, but then when we opened it, we found that okay, it is doing well. The implant was well fixed. We got away with simple plating. This is a B2 type fracture. This is not my case, taken from the internet, but it shows that there on table, definitely the implant was loose. Then again, the whole thing was revised, even the cup was revised. This is another B2 fracture, a little bit variant, where you can see the whole of the fracture running up to the GT. It looks like an extended trochanteric osteotomy. Okay, these fractures are usually very unstable. So if you see this kind of fracture, be prepared, this will need full revision. This is a B3 type of fracture where there is a lot of comminution. Now these are challenging fractures because there is a lot of bone loss, you don't know how to fix them. There is nowadays good plates are available, perisprosthetic plates are available, very long modular plates. You can use them, but you may need to use stud grafts, like a fibular graft has been used here. A stud graft is helpful sometimes. Some cases are very, very bad cases where actually you can think about femur replacements. That's mega processes femur replacement. This is another B3 type. Here also you can see this was a very badly comminuted fracture, but it was well fixed with cables only and revised. This is a type C fracture, much away from the implant itself. The implant looks stable and was managed with only a distal femoral locking plate. This is another just for a case discussion. So what do you think about this fracture? Well, where will you, this is a post-operative periprosthetic fracture. So which type? Anyone want to answer? This is definitely B because it is coming from the tip. Okay, this fracture is coming from the tip. It looks like maybe B1 or B2, doesn't look too comminuted. So we will be prepared with actually B2, we should be prepared with full revision. Fortunately, on table it was found to be very stable and it was only fixed with a distal femoral locking plate on the from the other side, from the other leg, and it was reversed to match with this contour. And these plates actually work very well because it just simply matches on the GT and you can get away with simple Indian plates also. Yeah, just a minute. So the armamentarium which you need to keep as periprosthetic plates, ample cable and SS wires, Morland set for removal of cement from the femur, explant acetabular osteotome system. This is a system which is available with most of the companies, but unfortunately they will almost never give you unless you specifically ask them for this. This is a very good system to take out uncemented cups. Sharp osteotome nibblers, revision implants, bone graft, blood, ICU, and definitely a friend or a senior, another orthopedic surgeon to help you out in this, bail out in these cases. If you are in a high volume center, it is recommended that you have all this armamentarium as a backup always in your OTs. This is a special type of plate from Synthes. This is a very modular kind of periprosthetic plate. You can extend this plate, you can have a GT extension, all these extensions are available. Thank you.
Thank you, Dr. Khemani. Now the session is open for discussion. Any question from the house? Any confusion?